Yeah, welcome along to the first in our series of young adults living with type 2 diabetes webinar series. So this is like your introductory webinar, giving you the real base good understanding and tools to help manage your diabetes moving forwards. So it is part of the NHS Sussex series created for people between 18 and 39 who are living with type 2. These sessions are designed to give you knowledge, tools, and confidence to take control of your health. So just a quick note before we begin. My name's Fran Taylor, and I'm a health improvement for Sussex Community Foundation Trust, and I've been organising these webinars. And we have the lovely Sarah Gregory, who is a diabetes specialist nurse, who's going to be talking through the webinar for you and leading that. This is a safe and supportive space, so your cameras and your microphones are off and your name is not visible to anyone else. You can send questions at any time through the Q&A box, and these will stay anonymous, and we will answer these questions at the end. So whatever questions you have, please do make use of this time and put those questions in the Q&A box, and we will look forward to answering them at the end. You will get a recording of this as well, so feel free to make notes, but you will also get the recording of this as well. And just a quick reminder as well that this session has been developed by, as I said, NHS Sussex. So its content is tailored to the local NHS services in Sussex. So it's for your education and support. It doesn't replace personal medical advice. So always speak with your GP or diabetes healthcare team before making any changes to your care. So I'm, as I said, delighted to introduce Sarah, who's going to be talking to us about kind of a Diabetes 101 session for those under 40 to give you some really good understanding. Sarah will present for what we're reckoning, Sarah, around half an hour, 45 minutes, and then we'll move on to your questions. So I'm going to share some slides and I'm going to take myself off the screen and I will monitor the questions. Please do ask as many as you want, and we'll answer those at the end. So over to you, Sarah.
Thank you, Fran, and thank you for everybody for attending this evening. And I hope that after the next half an hour, 45 minutes, we managed to give you a bit more of insight into what type 2 diabetes is and how we manage it. So a bit of, like we said, a bit of a 101 Q&A session and a bit of introduction to type 2 diabetes. Fran is going to share the slides, so I do feel a bit like Chris Whitty during COVID, if any of you remember that, because this is one of the first of the series, so we're just getting our heads around all technology like you do. So when we say about understanding your diagnosis and taking control, I'm not that keen on the word control, except that it needs to come from you. Okay, so what we're going to be talking about this evening is about how you manage your diabetes, and it's a case of knowing what type 2 diabetes is, knowing what your numbers and ideas should be, and then sharing those with your usual healthcare provider. Thanks, Fran. So Fran has already explained how this was developed. It is an NHS Sussex webinar. The content applies nationally, but some of the services vary slightly differently across different ICBs and NHS trusts. Thanks, Fran. And as I say, the overall aim is to give you knowledge and confidence to help you manage your diabetes. You actually only see healthcare professionals for about 2 hours a year. So what happens to your diabetes the rest of the time when you leave our room or you leave our video screen? Thank you. So if we go back to real basics, some of you might have done biology at school. It's a long time since I did biology. And if we just go back to how we use energy, so we know that carbohydrates are broken down to glucose, and that's a key thing to remember actually, because people think that it's just sugar that contributes to diabetes and glucose levels, and it's not. It's all these things that we group together as carbohydrates. So things like our fruit, our bread, our cereal, our pasta, our rice, anything else that's in that carbohydrate group gets broken down to glucose. Now, if you don't have type 2 diabetes, that glucose is used as energy in every single cell in our body. And, you know, this little key here is the insulin. So insulin is the key that unlocks that cell to let that glucose into the system to give us that energy. Okay. Okay, Fran. Now, with type 2 diabetes, you still eat and drink like everybody else. Your blood glucose then rises because we know that that carbohydrate is turning to sugar. Okay, but there's a bit of a delayed response with that process, and you can see here, and I'm going to explain this a little bit in a while. You may have heard of the term like fatty liver or fatty pancreas, and that's where we cannot store all the glucose that we're making, and we can't use it either because those keys don't fit, like down here in number 7. Okay, so that glucose can turn to fat in the liver. Okay, because the liver's still working. The liver is still producing glucose, despite what the pancreas is doing, despite what the insulin's doing. Okay, and if you can imagine that these keys, so normally we only need one key to open one cell. Let that glucose and energy in, off you go, you're set up for the day. Okay, so so that's where we are normally. Now, with type 2 diabetes, we have a bit of a process that the body, the pancreas, tries making extra keys. Okay, and it's a bit like in a hotel corridor where you've got 100 people but only 30 rooms. So only 30 of those keys are going to fit. Okay, so you're making insulin, you're making those keys, the cells just aren't responsive to them. So the pancreas then thinks, okay, right, what I'll do is I'll make more keys so that we can open more doors. That just means there's more people in that corridor. Okay. And what the body does is that it attempts to flush some of that excess glucose out. So some of the symptoms of diabetes, you might remember saying, oh, I was peeing a lot, or I was really thirsty, and I was getting up at night to pee, and I never did that before. And that's where that your kidneys are thinking, hang on, I'll help out a bit here. I'll try and get rid of some of this glucose. Okay. And if you are getting rid of a lot of glucose, then that can lead to urine infections and thrush and things like that. So if some of these symptoms are starting to make a bit of sense with this process, then I'm happy with what we've already talked about. Okay, thanks, Fran. So let's have a look at the Mythbuster. Now, you know, when we go on to lots of social media groups, there are a lot of myths around any long-term conditions, but diabetes seems to be quite a popular myth and quite a popular debated topic. So is it myth or is it true that type 2 diabetes is where we don't produce insulin? So just have a think. Okay, so we know it's related to insulin, we know it's related to glucose, but if we can just uncover the truth, Fran. Okay, so like I've just said, that you are making insulin with type 2 diabetes. So type 1 is where you don't make any insulin. People need to go onto insulin injections. Okay, with our type 2, I'm going to go into the process of the development of type 2 diabetes. Thank you, Fran. So if you think that visceral fat, now when I talk about visceral fat, That's the fat around our organs, okay? It's the bad fat. We don't want it there. And it sits around our middle, okay? So around our tummy, and it encases, you know, these organs in fat that we don't actually need, okay? And this is, so it sits around those essential organs. So it sits around our liver, it sits around our pancreas. Now, there's two parts to this cycle. And if you think that they both work together, so it's called a twin cycle. You've got the liver, you've got the pancreas. Now, with the liver cycle, like I've said, that liver stores that extra glucose. When it can't store it, or when it can't store it as glucose, or the body's not using that glucose, it then converts it to fat. So when you're diagnosed with type 2 diabetes, it's not unusual to have a raised cholesterol or triglycerides in the bloods. And some of you may have been diagnosed with high cholesterol, high blood pressure before you were diagnosed with type 2 diabetes. Okay, because this process can often start years before we start seeing that the pancreas cannot respond to that high level of glucose. So if you can imagine that the liver is full of glucose, full of fat, it's coming up to Christmas, and he thinks, right, I need some of this storage because I'm going to be busy. A bit like when we use our freezers. So I don't know about you, but I take all the stuff out my kitchen freezer or put it in the other freezer in the garage, package it up because I know I need that space. And that's kind of what the liver's doing. But the liver sends it off to the pancreas, okay? The pancreas doesn't like that. It makes it dysfunction. It makes it a bit sluggish. And then that means that the pancreas becomes fatty and it can't produce as much insulin. So then it can't keep producing those keys, okay? So instead of having 30 keys or 100 keys for 30 rooms, you might drop down to 70 keys. You might drop down to 60 keys. And this happens over a period of years. And it's called the twin cycle hypothesis. So if any of you have done A-level biology and think, I want to know a bit more about this, that's what Roy Taylor, who's one of our leading consultants in the twin cycle hypothesis, talks about. Okay, and both of these start a long time before those high glucose levels are detected, because eventually the pancreas won't produce as many keys, and then you're not seeing any keys get into those rooms, okay? And that's when we start seeing the high glucose levels. Thank you, Fran. So you might have heard type 2 diabetes is also linked with the metabolic syndrome. So some of you will be sitting here thinking, oh yeah, I've heard that. Okay, what does that mean? It means the primary problem with metabolic syndrome is insulin resistance. So that's my hotel corridor analogy. Okay, when the cells are resistant to those keys, so they can't open that door. Okay, so the body doesn't use that insulin properly. So we've got a load of insulin floating around. Okay, we just can't use it properly. We know that too much glucose is made by the liver, and we know we have problems metabolizing that fat. And then as time goes on, we stop producing enough insulin, okay, over a period of time. Like I've said, you'll commonly find this around and almost married to high cholesterol and fats in the blood and high blood pressure. Now, what's important that we uncover type 2 diabetes sooner rather than later. And some of you may have been diagnosed with a term that we call pre-diabetes, where you're in that very narrow range where your glucose levels aren't normal, but they're not in that type 2 range, okay? Now, once you tip into type 2 diabetes, and by the time diabetes is diagnosed, you may have lost 50% of those insulin-producing cells in the pancreas. So the pancreas has been kicked a little bit, really, and it's holding up its little white flag and says, you know what, I can't do anymore. I'm doing my best, but I can't do anymore. So when we talk about medication, we're going to talk about drugs that try and preserve your pancreatic function, okay? And that's why there's a lot of screening programs around to try and detect type 2 diabetes sooner rather than later. Thank you, Fran. So some of you will say, well, I don't get this, because if you're saying that I've got a lot of fat around my organs, I'm not particularly overweight. And my friend, she's twice my size and she hasn't got diabetes. Now, that's all to do with our fat threshold, okay? So if you're of an Asian or ethnic minority, your fat threshold, i.e. what you can tolerate, is a lot lower than your white counterparts, okay? So it depends where our fat's distributed. Now you can see here on this bottom one here, this is what we call apple shape. Can you see that all that fat is around those vital organs? Okay, this person's bigger, but their fat is spread all over. Okay, so it's not crowding their vital organs here. This person is pear-shaped, so but again, their adipose tissue, their fat, is more in their hips rather than around their tummy. And then this person is of a normal weight. You can see that they haven't got a lot of fat around. Okay, but you will see people, or you might be that person where you're not particularly overweight, but you've been diagnosed with type 2 diabetes. And it doesn't seem fair, and it is all to do with our personal fat threshold, where we hold most of that weight, and also our genetic predisposition as well. Thanks, Fran. So let's have a look at this Mythbuster number 2, and I think I've answered this, because it says you have to be obese or over 40 to develop type 2 diabetes, and we've already said that's not true. As for some of you sitting on this course, you are under 40. Okay, now when I came into diabetes a long time ago, it was fat and 40, type 2, thin and under 40, type 1. We know that's not the case anymore. And we know that there's a lot of people with type 1, that insulin-dependent diabetes, over the age of 40. And we also know that there's a lot of people with type 2 diabetes under the age of 40, and not all of them are overweight. Thanks, Fran. So what's our risk of developing type 2 diabetes? Okay, so if you've got a parent with type 2 diabetes, your lifetime risk is 40% to develop that yourself. Okay, if both of your parents are affected with type 2 diabetes, 70% risk of developing type 2 diabetes. It is more common in the South Asian and Black Caribbean community, because remember where we hold our fat. And also, if there's any women on this call that you've had gestational diabetes, okay, so that's diabetes in pregnancy, you've got a 50% risk of developing type 2 diabetes. And you might not have known that, okay? So you know, when you finished on the call, think that actually there's some factors I can change, some I can't, okay? I can't change my age, I can't change my ethnicity. Can't change the fact that I've had gestational diabetes, okay? I can't change my age as much as we'd like to, and I can't change any damage caused to the pancreas, okay? What I can change is the food and drink that I choose to have, or the lifestyle that I lead, the amount of activity I do, and also, this is really important, that weight. So if you think of our personal fat thresholds, even if you've got a normal BMI, the work done by Roy Taylor around that liver pancreatic cycle showed that even those who have a normal body weight, by losing 5% of that, they actually could reverse their type 2 diabetes. Okay, so it's worth thinking about. Now, the reason there's a lot of, I suppose, interest in early onset, so those under the age of 40, okay, is that it's becoming more common. Okay, so we know that 6% of the population have high blood glucose, that pre-diabetes, but they don't have type 2 yet. 4.4% of people have type 2 diabetes. So there's more people under the age of 40 with type 2 diabetes now than there is with type 1 diabetes. So can you see the massive shift we've had since I started doing diabetes? So the reason that we're running these programs and the reason that we're investing time, money and these kind of things in this is because the longer you have type 2 diabetes, the more aggressive it can be, causing those potential complications earlier. Okay, and we're trying to reduce that risk of complications to improve quality of life and avoid any serious health problems later on. So when we talk about complications, we're talking about heart and kidney disease, not just glucose levels, but also what's our high blood pressure doing, what's our cholesterol doing, what's our weight doing. All of these are very much intertwined with our young onset type 2. Thanks, Fran. So, mythbuster number 3. Most people who are diagnosed have clear symptoms. Okay. Now, not all of you will know that some of the symptoms you had were related to diabetes because they can be mild and easy to miss. So think about when you were diagnosed, okay? Were you thirsty? Were you peeing a lot? Did you have a wound or something that was slow to heal? Did you go to the opticians and they said, oh, your vision's got worse? Was your vision blurred? Because we know that those little vessels in your eyes are one of the first ones to be affected. So you might have said to your husband or wife or partner or family member, do you know what, that's the second time I've been back to the optician. They've changed my specs because I can't see long distance. It's because your vision's becoming blurred from that water behind the eyes. How many of us feel tired? I do today. Been training since 8 o'clock this morning, and now I'm thinking my battery's getting a bit low. But how many of us put that tiredness down? I've had a long day, I've been busy at work, I've been running around after the kids or the grandchildren or whatever. Okay, and we dismiss those symptoms as part of diabetes. Some of you might have had recurrent urine infections or thrush. Okay, some of you might not have had any symptoms, but if I was a betting person, I would probably say when you look back at it, you could probably relate to some of these symptoms. Thanks, Fran. So how do we make a diagnosis? So when I speak to people who have got diabetes or newly diagnosed with diabetes, I generally show them this chart. Now, if we come into our red or dark orange zone here, this is what we call normoglycemia. So that's our normal glucose level ranges. Okay, so if you were to do a fasting blood glucose, okay, we would expect that to be below 5.5 or below. Okay, if it was a random after you'd had a donut or a big heavy carby meal, we might think, okay, 7.8, yeah, 2 hours after a meal. And then we talk about HbA1c. Okay, so HbA1c is what we use to measure that average glucose. So when you were diagnosed, you would have had a HbA1c done. You might have had 2 if you didn't have symptoms. Okay, and that HbA1c should be 41 or below to be normal glycemia. Now, when we come into what we call non-diabetic hypoglycemia, pre-diabetes, you can see that we've got a very narrow window here, 42 to 47. And then we've got our fasting and our random glucose here. We don't tend to use fasting or random to make a diagnosis of type 2. We go with the HbA1c. And then you can see that diabetes is in the dark blue. Okay, so a HbA1c of 48 or above is indicative of type 2 diabetes. So I just want you to ask yourself, do I know my HbA1c? You should know your HbA1c, because you should know what your target HbA1c is and where you are now. Okay, so when you're newly diagnosed with type 2 diabetes, okay, we like your HbA1c to be here. If we can tip it back into the green zone, brilliant. And you might have heard remission, the term remission. Or we might say, actually, remission's great, but actually there's some drugs here that I will need you to take for your diabetes that actually protect your heart and kidneys. But we might still want you in this green zone. Once you start nudging towards 64 and above, you start getting into that area where you're at higher risk of complications. And we have that, I don't know if we've got this on our slide, but I often use, I don't know if you can see it, I often use, you can't see it, it's a little chart, and I explain it to patients in their red, amber and yellow zones. Okay, so know what your number is, and then ask your healthcare professional, what's my target? Or actually you say, this is what I want my target to be. How am I going to get there? Okay, thanks, Fran. Okay, so once I've been diagnosed with type 2 diabetes, I can't change anything. Is that true or is that false? So we've talked about those modifiable risks. Okay, so actually you can change it, and we've talked about remission. Now, to achieve remission, the best time to do it is when you're newly diagnosed or within 6 years. We always try and advocate a year, and that's down to Roy Taylor's work. Remember that liver and pancreas cycle. Okay, so you can put your diabetes into remission by lowering your HbA1c to below 48 without any medication for 6 months. So you might be offered what we call a structured education course. Please take it, or please look at what's in your area, because I promise that will give you those tools that you need to achieve remission. Okay, you need to know what you're aiming for. Now, it might not be right for you, and I look after a lot of people who are young, under 40, and actually when we have the discussion, they might say, well, actually I'm on some drugs here that I know protect my heart and my kidneys. If I have the title remission, that stays on your GP notes as diabetes in remission, because you still need your eye screening every year, and you still need your annual review every year, and your HbA1c every year. Okay, it's just holding it at bay. Now, to do remission is tough, okay, because you might have heard the soups and shakes diet. So get yourself on structured education first. Know what type 2 diabetes is, and this is your first step this evening. Okay, understand a bit more about carbohydrates. Okay, what they can do, can I reduce them, what do they mean for me? And then the remission program, you've got a bit of a head start. Now, it's a 12-month program, and you can either have one-to-one face-to-face or one-to-one digital support, so it's not done in a group. This is the hard part, and I wouldn't do it in the winter. If you're going to do it when the spring and summer are coming, because if you're only having 800 to 900 calories and you're losing weight, you get a bit cold, unless you're like me and you're having hot flushes. So 800 to 900 calorie diet replacement, not instead of, or not in addition to what you already eat. You've got to put that aside, okay? And you have your soups and your shakes for 9 months, okay? Or for 3 months, and then they gradually introduce your other food, okay? But if you think, oh, I don't know if I could do that. I couldn't do it. I'd really struggle with that, okay? But don't worry, because it's something to think about. But actually, do yourself the biggest favour and keep your glucose levels as close to normal as possible. Set yourself that target of 48 with or without medication, okay? And we're doing a session on medication and we go over which ones are that cardio renal protective ones. Thanks, Fran. Okay. So, like I've said, we need to talk about other things, and these are short, sharp sessions, okay? Because we don't want to keep you here for 3 or 4 hours in one go. That'd be hard work for all of us. So what we're looking at, and the sessions I'm delivering coming up, and the dates will be advertised, is around looking at the lifestyle, activity and weight management. What does that look like for me? All my GPs ever said to me is go away and lose weight. Well, how? If it was as easy as stopping what goes in my mouth and exercising more, none of us would be overweight. Okay, so what tools and tips have we got to help you with that? Okay, and then the other thing we're looking at is around medication for type 2 diabetes, and it's not just about glucose. It's around those other drugs that protect our heart, protect our kidneys, help with blood pressure, help with cholesterol, help with all of those things. Okay, so today's just a taster for what's to come. Thanks, Fran. So thank you for participating in this session. I will ask now if anyone's put any questions in the chat or in the Q&A one. Okay.
Yep, and thank you so much, Sarah. That's you explain it all so brilliantly. It's really clear and it's a really great kind of overview, really. I think if people have been recently diagnosed and they're kind of, unsure of the basics, that's a really brilliant way of explaining it. And we have had some questions come in. I'm going to just stop sharing the slides for now. And I am going to just have a look at the questions that are coming through, just to kind of reiterate what Sarah's said. So medications session is coming up next Thursday, and weight management is in October, but you will be getting the recording of this, and we'll get a link with all the upcoming ones that you can book onto as well, and you probably should have had a link anyway previously. So bear with me 1 second. Let me just have a look at some of the questions coming through. So one question is, it says, I've been recently diagnosed, and it's kind of quite overwhelming. So like, what's good to focus on first?
So I think the first thing to focus on actually is know your numbers. So get to grips with knowing what HbA1c means, knowing what your blood pressure is and your cholesterol. Okay, so that when you go in to discuss your diabetes, that's the first thing you talk about. What's my HbA1c now and what are my targets? What do I want to achieve and where and how do I need to do that? So just, I would say, focus on those very basic things first of all.
Yeah, that's really nice, and links quite nicely into another question, which is, so how quickly will I notice any change? So if I start making changes to how much activity I'm doing and what I'm eating, like how quickly does that translate into HbA1c? When will I start noticing those changes?
So the HbA1c is obviously done at diagnosis. And then when you're setting targets, so when you're looking at what your target is, and it may be an interim target, it may not be that final target of 48, you might set an interim one. We wouldn't recheck that for 3 months. So each time you've got a 3-month window to make those changes. So that's either structured education, okay, or starting a new medication, but we would monitor that normally every 3 months. Sometimes it's 6 months. I think with our young adults who are new to this and who we really need to help bring that HbA1c down, I would say every 3 months.
Right. Okay. So that's something that they should go back to their doctor and kind of have that conversation with.
Yeah.
Brilliant. There's lots of information out there, isn't there? As you kind of alluded to, like social media is, you can hear whatever you want to hear, essentially. So what is some good kind of reliable, trustworthy sources if people kind of come away from this and they think, oh, actually, I do need to find out a bit more and I do want to look at making this change? Like, where shall they go?
I think the first, look at your local resources for Sussex, okay, because you'll have a website for Sussex. But
Yeah.
nationally, I would look at the Diabetes UK website. You might now, the Diabetes UK website is a national charity, okay? They fund a lot of research and everything on there is evidence-based, okay? There is another charity called diabetes.org, and they run slightly different to Diabetes UK. In fact, they're more set up by patients, I guess. So it's not a bad thing, but if you want that evidence research-based information, then I would go to Diabetes UK, and I would avoid things like forums and things like that, Facebook pages, because you're only going to get people's experiences and they might not always be positive.
Yeah, and it's what, as you say, it's one person's opinion.
It's subjective, isn't it?
Yeah. So Diabetes UK and NHS Sussex resources are your go-to places. Okay, just one more question that's come through. So someone has, so I've been living with diabetes for 3 years and I'm on some medication. How do I know, like, should I, do I stay on that? Like, how should I change it, or should I ask the doctor to review it?
I think we cover that in the medication session.
Yeah.
And I always refer to diabetes medication as what might be on my pantry shelf. Okay, it's what I can pick down and put back up. So it's important to know how your medication works and what it's doing, and if it suits you, and if that's what you think, okay, yeah, that sounds good. A lot of medication now all medication now has to go through rigorous trials to prove its benefit protecting your heart and your kidneys. So some of the older medication didn't have to go through that. So I think if you want to know more about medication, then probably next week's
See you here same time, same place next week.
Yeah.